So I'm going to argue that surgery is and continues to remain the preferred approach for good risk patients with early stage lung cancer. And this comes down to the natural history of how we treat lung cancer. For the better part of the last century, surgery has been the best form of treatment for early stage lung cancer. And the fundamental tenets of the anatomic surgery approaches that have developed include complete R0 resection of the primary tumor, along with its associated bronchovascular unit. So we're not trying to resect a tumor within millimeters, but we want to resect the entire bronchovascular territory that supply the tumor. We do pay attention to margins in that vein, and also systematic mediastinal lymph node staging that is done preoperatively and, importantly, intraoperatively at the time of lung resection. And this is the standard of care for early stage lung cancer and affords patients the best chance of cure. And that's dictated here. When we look at the survival curves for clinical and pathological stage 1 lung cancer, we're talking about 70% at 5 years. And so that'll be the hallmark that we have to compare our data to as we consider any non-surgical ablative modalities. As I mentioned, anatomic surgical resection of lung cancer has evolved dramatically from pneumonectomy in the 1940s to lobectomy by the 50s and 60s, and now most recently anatomic segmentectomies to address small tumors. The first pneumonectomy was performed in 1933 and was associated with a very high mortality, but was believed to be the best chance of cure. Dr. Ochsner emphasized it's our firm conviction that any procedure short of total removal of the involved lung is irrational, and only by total pneumonectomy can the primary focus as well as the regional lymph nodes be adequately removed. So nearly 100 years ago, we understood the importance of not only removing the tumor, but removing the bronchovascular supply. And that's something that is not done with ablative modalities. As time went on, it became clear that we didn't have to remove the entire lung to achieve good results. This was a retrospective comparison looking at the Ochsner and Overholt clinics, and basically showing no significant difference in survival between lobectomy and pneumonectomy, which correlates similarly with the evolution of surgical approaches to breast cancer, for example. You don't have to remove the entire lung, but you can remove a focus lobe. And the other thing that's interesting about this is that the extent of disease, not the extent of surgery, dictates the differences in overall survival. And this was firmly established by Dr. Churchill in the 1940s and 50s and continued all the way up to current time, really. It remains the standard of care now, lobectomy for lung cancer. The primary prospective randomized trial that cements this concept is the Lung Cancer Study Group, which looked at 125 lobectomy patients versus 122 limited resection patients, which included both wedge and segmentectomy. And what this trial showed was that lobectomy was associated with better locoregional control, but really no significant difference in overall survival. But it was this study, more than any, that was really cemented lobectomy as the standard of care for early stage lung cancer. Sublobar resection in this trial, which took place in the pre-PET era, pre-EBUS era, was associated with a threefold increase of locoregional recurrence, but equivalent overall survival. As time has gone on, work from Japan and in the United States and Dr. Landrino, we've had the privilege, has really energized the concept of segmentectomy in the United States. And we looked at our experience with an anatomic segmentectomy, again, removing the entire bronchovascular unit while attaining an R0 resection and negative margins. And we found that anatomic segmentectomy was not associated with any difference in overall recurrence rates or overall survival, and was not a predictor of adverse outcomes in terms of recurrence in multivariate analysis. And this is the largest propensity matched comparison in the literature. And so really until the publication of the CLGB trial, this is the closest thing that we can get to best evidence. And anatomic segmentectomy, I would argue, provides an excellent alternative to ablative approaches. It has very minimal mortality risk. Mortality for lung cancer surgery has gone way down. It's well below 8%. Most recent studies show lobectomies about 1% and segmentectomies as 0.7 to 1%. There's the opportunity for lung preservation with segmentectomy. It's especially good for solitary pulmonary nodules that we will encounter increasingly with screening, and Dr. Wilson will be talking about that. It's excellent for metastasectomy, where you can preserve lung but achieve R0 resections. It's excellent for ground glass opacities with low metastatic potential. And again, it gets right back to the fundamental tenets of R0 resection with systematic nodal staging. And what we have found in our studies of segmentectomy and lobectomy is that, taking more tissue does not enhance survival, but taking less tissue does not accomplish a fundamental R0 resection or provide definitive information on systematic nodal staging. Our techniques have evolved to VATS, and we've had extensive discussion with VATS. Now here at UPMC, this is an older slide, but well over 80% of our cases are now VATS for lung resection. And robotics is taking an increasing role in that. We've talked about that. Any VATS approach that we take is going to emulate what we would do open, but we just do it through smaller incisions. And this is showing the mortality trends over the last 90 years. And now most modern series publish mortalities for lobectomy and segmentectomy is less than 2%, generally right around 1 to 1.5%. So if we're going to compare surgery to the non-surgical ablative modalities, we could take a look at radiofrequency ablation, which is the subject of our next talk. And I just want to point out some of the challenges that we face with these ablative modalities. As surgeons, we're actively involved in these ablative modalities. We perform the radiofrequency ablation here at UPMC. We participate, as Dr. Heron said, in the SBRT program. So we are very cognizant of the limitations and challenges that we face. I would say the biggest challenges that we face with radiofrequency ablation is pneumothorax rate, which ranges between 30 to 60%. Generally, it's very safe, and you can attain a very good radiographic burn. But as we found in our initial experience, that recurrence rates were high, and overall survival was less than optimal. Now, granted, these are high-risk patients that were not conventional surgical candidates, but the 2-year survival was only 48% for lung cancer, 64% for recurrent lung cancer, and 41% for metastatic lung cancer. In a series of studies looking at radiofrequency ablation, the one statistic that really stands out, and I think the Achilles heel currently of radiofrequency ablation, is local progression, and local recurrence, which is much higher than what we see in surgery. Surgery local recurrence rates are about 5 to 7%. That's local regional recurrence rates. That includes regional nodal recurrence. But in radiofrequency ablation, local progression is quite high. And I think that's what's limited the use of radiofrequency ablation more commonly. As far as stereotactic radiosurgery, we heard the excellent results in the improving technology. Multiple studies now showing excellent 80 to 90% primary tumor control rate. But I think when we look at this literature, we have to ask several questions. What are the definitions of control? What are the definitions of recurrence? They're not always exactly the same as the surgical literature. So comparing between studies may be difficult. In some instances, apples and oranges. Though stereotactic treatments are attractive because they're very non-invasive, there's no cutting involved. There still are significant complications that can occur, including which are predominantly pulmonary, COPD exacerbation, pulmonary toxicities, including full-scale pneumonitis, hemoptysis, fistula formation, and death has been reported as complications after SRS. So it's not an entirely benign procedure. Here's a patient who had a small apical lesion in the left upper lobe and with significant pneumonitis after SBRT. So it's not entirely benign treatment either. And when we try to apply, the use of SBRT has really evolved for patients who can't undergo surgery. And as Dr. Heron pointed out, we're now beginning to ask, can we use it in good risk patients? There have been some studies that have compared this. This is a National Cancer Database trial looking at 13,000 patients who underwent lobectomy versus 1,700 patients that underwent SBRT. Median follow-ups right around 30 months. And they examined the outcomes. And there were a couple of interesting findings, is that the pathological nodal upstaging in the surgical arm was 12%. And 70% of those individuals received adjuvant therapy. And that may be a missed opportunity in patients with SBRT that don't have the same opportunity for intraoperative nodal staging. And overall, the adjuvant therapy was much more common in the surgery arm as a result. Lobectomy in this study was associated with improved overall survival compared with SBRT for both clinical T1 and T2 tumors. And again, these are patients that were felt to be operative. They define this as those who have basically no comorbidities in the form of a Charlson index. And they also looked at the descriptor of folks who could have had surgery but refused surgery. And that's what these two curves depict. In the no comorbidity comparison, though there is an early mortality effect from the the front end risks associated with surgery, over time that mortality risk dissipates and there's separation favoring surgery over time. At 5 years, 59% versus 29% overall survival. And this is from the National Cancer Database. And for patients that were deemed surgically fit but refused lobectomy, there was also a significant difference favoring surgery. So I think the jury is still out in that regard. Another retrospective analysis looking at patients greater than age 65 for stage 1 non-small cell lung cancer that were deemed potential surgical candidates. It was a comparison of 400 VATS lobectomy patients versus 378 SBRT patients. The populations were matched for patients, and that's something we have to take into account. Pathological upstaging, again, 28% in the surgical arm, over half of which went on to receive adjuvant therapy. And again, potentially conferring a survival benefit because of the recognition of pathological upstaging. And what this study found was significant improvement in overall survival, favoring VATS lobectomy in the overall group in the first 15 months and after 15 months, and a significant improvement in overall survival favoring VATS lobectomy after 15 months in the propensity match cohorts. And that's shown here. The first curve showing the overall group, the second curve showing the propensity match groups, favoring VATS. So in conclusion, non-operative ablative therapies for early stage lung cancer are here to stay. Patients will continue to demand it. The technologies will continue to improve. I think we have to embrace it. Image-guided ablative therapies may be curative in cases of early stage lung cancer, but I would argue that surgical resection still remains the gold standard, and that non-operative ablative therapies are best reserved for high-risk patients who are unable or unwilling to undergo surgical resection, and longer-term outcomes, and ideally prospective randomized comparisons will help us provide the best understanding of this. As we've been talking about all morning and afternoon, surgical therapies and associated technologies will continue to evolve. I would say lobectomy is still the gold standard, although segmentectomy is emerging as a possible excellent option for small tumors even in good risk patients. And especially in the lung screening era, I think segmentectomy will play an even more important role. And lastly, it's the same thought that Dr. Landreneau has always emphasized when we talk about surgery versus ablative modalities, is that only with complete resection of the primary tumor, the entire bronchovascular unit, and as well as systematic regional nodal staging, are we really achieving the fundamental tenets of surgery. And also, in removing the tumor, you also have the opportunity for tissue assessment, pharmacogenomic and immunological analysis, again, which may be harder or less complete in an ablative setting. So thank you. That's it.
Very much. We'll take a few minutes for just a few questions.
Skinny 11.
Okay. I'd like to ask Dr. Heron, is Dr. Heron here?
Yes.
Hey, what?
Hiding in the back.
Hi. We found you. So Dwight, my question is and we discussed this like 8 years ago. I was looking through the literature at ASCO, and there's some guy out of Detroit. I keep asking you about his name. He's some radiation oncologist over there. And he was looking at the experience with hypofractionation. We've had this discussion for advanced stage disease. We're talking about hypofractionation for early stage disease. Now, I know you need to modify your physics, et cetera, for those issues for more advanced disease. But in Asia, specifically in India and in Africa, that's what they do because of the resource allocation.
Yeah.
So why don't we do that here and not worry about the 30 days of billing?
Well, have you seen the top?
And just do the 4 days of billing.
Well, good point. The outcomes are not the same. And the toxicities, well, they're not. But to your point, I think, we're moving to hyperfractionation for a lot of things. We've done it for breast cancer. We've done it for prostate cancer. And the challenge is the radiobiology. It's a biology question. And so we don't have all the studies to kind of get us there. But if you're going to do it, if you're going to do these larger doses, and you can get away with it in the breast, you can get away with it in the prostate, the lung is a different thing. It's a lot more sensitive organ to radiation. So I think we're in the process of working out the radiobiology. I think we're going to get there. I don't think we need to treat patients for 6 weeks. So we're not talking about, 30 treatments. The right number is probably 28 or something like it. I'm sorry, not 30 treatments. It's probably 24 or something like that. We can't use the same type of technique and doses that we use for radiosurgery for lots of other lung. It's just too big a field, and the side effects are too great to be able to try to do
my
that.
point, we have this, I'm just trying to be, to avoid the politics, which are impossible, and that is that we have this, beyond the equipoise maybe that might be occur for advanced disease, hypofractionation and long-term survival versus multiple.
Yeah.
We have the same equipoise issue with regard to early stage disease because of chauvinistic approaches, or that we surgeons want to do this, radiation wants to do that. But I don't know what's right on either side of it, and I'm a big supporter on doing the stage 1 project. But I think for advanced stage, we face the same issues with regard to just getting your physicists to do what's right, and bring them in there once a week around their radiation sensitizing chemotherapy.
Yeah, there's some data about, it's not once a week. It'd be, instead of it being 5 days a week, it's twice a week and doing larger doses, something like that. And there may be some opportunities there. You're right. In resource-constrained countries, that's exactly what they do. I mean, they've got to do fewer treatments. They give bigger doses and to do it fewer times a week. But I think...
A great study.
I think it would be a great study. I mean, you want to write it?
But you'd have 3 less secretaries, and you'd have what? You wouldn't be driving the same car.
Well, yeah, and we have, again, and there's an economic cost,
Yeah.
right? There is an economic argument here too as well. So I agree.
Quick question, just to catch both. I think for Dr. Heron and for Dr. Schucert, both, some of the studies that we show that are really trying to compare are so difficult to do. We're seeing the large Japanese studies, which some of the criticisms have been staging versus even non-diagnosis of the primary nodule, which I think is a big issue, versus the fact that a lot of the comparisons to surgery have been potentially been done in an era where really open thoracotomy has been the primary mode of treatment. And I wonder if some of the evolving techniques, like Dr. Gonzalez-Rivas is showing with robotics, where in higher level centers, really the mortality from these early stage operations should be 1% or less, really less than 1%, whereas we're seeing mortalities of 1.7%, 1.8, 1.9%. And do you think truly in the modern era now, what is the status quo? We don't know. We don't have a randomized prospective trial, but what's your thought or instinct regarding the real true comparison now between surgery and some of these things?
Yeah, I mean, I think that the local control rates for the SBRT are good, but I think one of the things I worry about is the question of staging, inadequate intraoperative staging, missing the opportunity for adjuvant therapies. I think that can have a palpable impact on survival, missed opportunity for improving survival.
I'd agree with that. And I think if that's why those 2 studies that I mentioned that were prospective is so important. And again, we have to, the data has got to get a wash out of the old bad stuff, right? So if you look at the modern era and our recognition that a lot of the early radiosurgical data, these patients, some of them didn't actually even have a biopsy. It was a presumption that it's cancer. And we know what that means, right? A lot of these patients probably didn't have cancer. But I think if you look at the more modern radiosurgical studies where they're in fact having, and that's what we generally try to do here, right, is we want to make sure that a patient that we're going to subject to radiosurgery, that they're truly stage 1, right? They're early stage, and we don't want to miss that opportunity of them having occult disease in the mediastinum. So we try to do that as much as possible. And I think, frankly, the real opportunity is with some of these minimally invasive techniques with radiosurgeries doing that comparison. The problem is, as I said, is this bias for one technique or another, and trying to get surgeons and radiation oncologists on the same page to say, listen, take these operable patients, right? And put them, randomize them through equally appropriately staged and randomize them to one therapy or the next. And a part of that too is educating our patients that, hey, for us to make progress, we're going to need to know, because no patient's going to say, yes, I want a surgery, right? And so that's a part of our lingo as clinicians, to make sure that when we talk to patients about clinical trials and talk to them about therapies, about options, we don't try to bias them one way or another. It's just, I mean, they may make a decision one way or another, but I think that's the problem we have as a component of it anyway, is that, you know, there are biases from the clinicians, and it can be a problem.
And our biases are clearly built in because we think they want it out.
Yeah, exactly. Yeah.
Did you guys give the non-SBRT?
Yes, Matt did cover quite a bit.
Some
Good,
of the
thanks.
issues, yeah.
Well, I apologize for being late, but a lot of good comments, and I know the talks already. But I do think that I gotta say I disagree to a degree with Dwight, and then I disagree with Matt to a degree. And what I mean by that is,
We're good. We're good.
well, no, because if you look at the data on querying patients simply by age, they are both right. If you ask your average 60-year-old, what do you want to do for this lung cancer? 90% plus are going to say take it out. I mean, that data's there. Now, you can bias them by telling, oh, you want to have it burned and they're probably going to miss it and then you're going to lose your chance for cure, or I can take it out. Well, of course, they're going to say take it out. But if you give them a non-biased presentation, over 90% at age 60 will say take it out, assuming good health. Now, you start going into 70, you're going to start to see that pendulum shift a little bit. It's not going to be 90% that want surgery. It may fall to 70, 60%, depending on how healthy they are, how robust they are, who the surgeon is, what are the options, what's the track record of the radiation oncologist, or what the other opportunities for ablative therapies. There are many opportunities that are coming down the road. But then you start to get up to 85 or 90. Now you got to twist your arm to go to surgery. And what's the fastest growing segment of our population? 80 plus. I met with a gentleman yesterday up from Florida with a cancer, stage T1A, already failed non-surgical therapy. He's still reluctant to have surgery. So we're looking at potentially another round. He's a golfer. We could get him through a minimally invasive surgical approach easily, for sure, with a risk of less than 1% to his life. But he's reaching that age where he's saying, wait a minute, I'm golfing every day. Now you're talking surgery, and maybe in someone's hands that's really good at it, like Nacho or Rivas or Richard or any one of probably our group could do it, but that's not universally available, and we don't get it right in 100% of patients. So some do have complications. So this guy is banking on, hey, if I can keep golfing and do something non-surgical with a reasonable approach, a reasonable outcome. Now, and I know you guys have covered some of the data, I would have to tell you that I don't think the data's there yet to say they're equivalent approaches. I would say, however, the patient choices, they're going to drive this. And if we don't get involved as surgeons, whether it's randomized trials or prospective controlled trials, or figuring out your own way to ablate, because soon it'll be a new game in town. It's going to be bronchoscopic guided, flexible ablative therapies. It's going to cut the costs. It's going to put the treatment back into the hands of pulmonologists and surgeons. Doesn't mean radiotherapy is going to go away. It just means there's going to be other options that are probably going to be cheaper. Will they be as good? Can you centrally deploy a needle? Can you get the same results? I think that remains to be seen. You know, it's still a debatable topic on what's the best approach, but what's not debatable is the patients, as they age, migrate away from deciding surgery as the primary therapy. Now, what can we do as surgeons? Get better and better at it. Uniportal, robotic. The less pain we inflict on them, the lower the risk, the more likely you're going to say, take it out. So all these are advancing at a good time because our population is aging. So we've got to keep up with them, and we've got to offer them choices. I think we have a little more data to collect to say that they're equivalent because of the reluctance of patients, clinicians, surgeons, and in some cases, radiation oncologists to randomize otherwise healthy, fit patients when we have a standard of care that's been around for 50 years, and now we can do it minimally invasively. So I think that that's still a debatable topic, and I'm not sure that we've reached the end of the road in terms of our ability to randomize patients. I think we're coming into an era where we can more likely randomize a group that is perhaps, even if it's just simply an age cutoff, we want to actually randomize the older patients because we know a lot of them may not choose surgery as their primary therapy. So now the question is, can you get them to enter a randomization where a flip of the coin might say, you're getting surgery. Maybe they didn't want the surgery. And then likewise, for the 60-year-old, flip the coin and say, you're not getting surgery. Says, no, I wanted the surgery. So it's been difficult for us, I think, across all aspects of medicine to drive level 1 evidence. We just don't have it in many, many areas. But this is one, at least where the choices are becoming more and more equivalent, and we'll see. But that's kind of my take on it, is that it won't be necessarily the fact that we can do it safely, surgically. I think it's going to be what do the patients want and what's easier. And for now, I think we do have some very good ablative therapies, and we've been doing them for close to 20 years here. I think partly because of our colleagues in neurosurgery that led the way with Gamma Knife, and radiation oncology has developed that technology with them. But that's how we got started, was working with rad-onc and neurosurgery to develop our own algorithms. And we do a lot of non-radiotherapy type ablative therapies, and that's getting better. But overall, the local recurrence rate was probably 10, 15% higher than even the early data. And we had a lot of local recurrences with the early data in the radiotherapeutic approaches because we probably weren't fractionating right. We probably were giving not a bioequivalent dose, it was a killing dose. We gave lower doses. And so we failed, but that was early on. So I think it's an exciting time. I think it's a good time for actually patients because they're going to have very reasonable choices versus that old data where you really couldn't cure cancer with radiation therapy. I think that's changed. We know that you can cure some tumors with radiation therapy if it's done correctly, you choose the right patient, et cetera, et cetera. So, questions from the audience? Comments? Yeah, Neil.
I just have one question, Dwight. At the World Lung Cancer Conference in Toronto, one of your colleagues from Western Ontario presented an ablate and resect protocol with stereotactic radiation. They gave therapeutic doses and then did a lobectomy 6 weeks later, and they looked at viability based on histology, and I was surprised. They found about 40% of the patients still had viable tumor, and it seems out of proportion to the outcomes that we're seeing. I don't know if you can explain that, or what's the timeline for the...
I actually can. This happens all the time. So again, this is how we counsel our patients, right? The effect of radiotherapy actually lags long behind its course. So we have a couple of models for this, right? So another epithelial tumor, anal cancer, right? So they did back in the 50s, 60s, and 70s this systematically, where you would treat the tumors, and every 6 to 8 weeks you would go ahead and biopsy. And actually out to 3 months, you can see what looks like still viable tumor. But if you follow those patients and didn't actually go ahead and resect them and do an APR on them, they actually all had a complete response. And so this is the same thing. There's actually been a couple of studies previously where they attempted to re-biopsy tumors over time treated with conventional radiotherapy. And so I am not surprised that 6 or 8 weeks later, 6 weeks later, you're still seeing viable tumor. It doesn't necessarily mean you're not going to get a CR. Again, it's size dependent, right? So if we're talking about the smallest tumors, it's easier to control those. We know for a fact that these 5 and 6 centimeter tumors, we have a hard time of controlling them with almost anything that we do, right?
What was the size on that study?
That was, I think, standard up to 5 centimeters, kind of our standard patients that we would do.
Up to 5 centimeters for SBRT?
Yeah, they treated them, and then they did a lobectomy 6 weeks later.
I would just say that I'm surprised that maximum size was that big, because usually when we're trying to compare these early stage cancers, we're talking 2 centimeter and less, but that was, they definitely took up to 5 cms.
I believe so, yeah.
It's probably because they're thinking that they're going to take him to surgery, and maybe one of the endpoints, a correlate was response. But 6 weeks, I mean, we have a bunch of biological clinical models that would explain why you're
The
still
plan
seeing
was for
tumors.
surgery for everybody. They just wanted to see.
Yeah, but I mean, still, I would have, if you wanted to get data that was, I think that you could extrapolate for what we're talking about today in general. I don't think very many people are talking about SBRT for 3+ centimeter tumors. I mean, obviously, if you have a patient that's not at all fit or refuses surgery, you might do a lot of things that you wouldn't say is your standard.
Yeah. But I think technically the cutoff is about 5 centimeters. Beyond that, you can't do it. Obviously, it's a compromised treatment if you extrapolate from all the surgical data, but
I mean, that's, to me, reminiscent of the old lobectomy versus wedge trial, of Ginsburg era, where they took up to 3 centimeter tumors. They didn't tell us what the margins were. It just wasn't a very good study. And even then, the local recurrence rate wasn't, or at least the survival rate never really showed a statistically significant difference over time. So I think to do that study the right way, in my opinion, you should have taken the game that we're playing, which is the small tumors. But it's interesting. Did they categorize it into how many of the tumors less than 2 centimeters were alive?
I'd have to look at it. I don't remember.
Size of the arms at all? A big trial?
It wasn't a big trial. It was only.
Look at that. I think that's an interesting study, because you would think that they would have subset analyzed, and if, because you might have 95% kill of the tumors that were less than 2 centimeters. Because we don't see a ton of recurrences. I think that some of those patients are well, at least in some of the studies that are out there. That's been my biggest argument against the literature, is that what you call a CR, in some cases, has been based on the appearance of the early CAT scan. The early CAT scan. The fact that there's a big inflammatory reaction is, that must be a CR. I mean, some crazy things are out there that claim results that led to, I think, a lot of criticism of SBRT, and us on the surgical side, at least here, we've been in bed with the radiation oncologists. We're working closely with them, not just because we think it's so handsome, but because we really had a very similar philosophy with seeking out, non-surgical means, even though obviously with Rod here and Matt and others, we're all into minimally invasive surgery for sure. But I think we've recognized that the future is, you got to be innovative. Surgeons have to be innovative. You can't say, there's a new technology, so I'm going to give up treating stage 1 lung cancer. No more than the vascular surgeons, they can put stents in an IR, I'm done. No, they developed relationships with IR and developed their own IR treatment operating rooms when necessary. But I think that's the key, is that we should be partnering with radiation oncology so that we are dead in the thing. And then as we evolve into these other therapeutics that are bronchoscopically guided, that's going to be interesting. I think, David, on the pulmonology side, what are you hearing in terms of bronchoscopic guided ablative therapies? I think that's really going to be an exciting innovation as it reaches perfection. I don't think it's perfected yet.
Well, I haven't heard of any human trials, but there's a lot of animal work, both using fiber optic bronchoscopy for endobronchial ablation, which is being done quite a bit. And also, there's been some proof of principle studies injecting chemotherapy and immunotherapy agents directly into tumors under image-guided bronchoscopy. So I think that in the near future, these techniques are going to be available on a clinical trial basis, but I think they're not quite ready yet.
Richard, you guys have comments about what your thoughts are?
I think that you're right about the population aging, and there's got to be a real critical assessment of who's operable and not. And when you're looking at doing non-surgical therapy, it really has to be an assessment of they're not fit from a cardiac pulmonary standpoint, and you're anticipating a limited lifespan, maybe 3 years or less, because there's differences in some of the data of survival comparing resection to surgery after 3 years. And we can debate that left and right. But there's a great paper that looked at 500 lung nodules identified on CT and PET that were felt to be lung cancers, no biopsy, and 10% of them, they all went to surgery, 10% were non-malignant, and of the 90%, 15% were stage 2 or 3. And the critical ability to have an adequate hilar as well as mediastinal node assessment is huge. Because if we're offering sublobar therapy to people, whether it's resectional surgery or it's ablative, got to make sure those nodes are clean, or else we're going to lose something on those patients. So if they're surgical and you can do it minimally invasive, the impact of, I think, VATS on poor PFTs and poor cardiac function is not the same nowadays. Our anesthesiologists, our preoperative medical evaluation optimization is better. Our ability to do things with less blood loss, less change in heart rate, blood pressure, that product, and getting them through the postoperative period is much better than it was 20 years ago. So I'm not a big... No, go ahead.
So Dr. Rivas, who's with us today, as you've all heard from earlier, has told me he's operated in a couple other countries besides the U.S. How many countries?
101.
101 countries. So in your experience around the world, probably more fast than anybody in the room, certainly more than mine, can you tell me what you're hearing? What's the buzz across the world? Do you think ablative therapy is going to take over for, when I say the younger patients, let's say those less than 75 that are fit and they have an opportunity to hook up with a surgeon of your stature or someone like us or Richard? Are you seeing them that would take a non-surgical approach?
Well, I think this is a very good question. What will happen with these patients because I think that the radiation therapy and ablation therapy is evolving very fast in the last years. So they are offering very good results. But I think that our role as a surgeons is to offer the less invasive approach to the patient. And this is why it's so important the technology and evolve and robotics and uniportal. And also the sublobar resections we do more and more to compete with them to offer radical therapy for these patients. But I think it's difficult to compete with them when we are talking about old patients. Because as we mentioned, patient older than 75, 80, the risk of this therapy is very low compared with the surgical resection. So it's a threat for us as surgeons, but we need to do our best to improve it.
Well, and you guys have, and I think uniportal is just another step in addition to robotics that allow us to offer less and less morbid procedures. But there are cases, and I'm pretty aggressive minimally invasive surgery, but there are cases when I have a 1.5 centimeter nodule dead smack in the middle of the lower lobe in an upper lobe predominant emphysema patient. It's not wedgeable. You might segment it out, but probably not if you're talking a deep a lower lobe tumor. You're looking at a lobectomy, which means a pneumonectomy equivalent in upper lobe predominant emphysema because there's very little perfusion in that upper lobe. So what are you going to do with that patient? You might say, oh, I could do a segment. Not always. And you can't certainly do it always minimally invasively. So what do? I mean, you're stuck with either doing a lobe or referring them for an ablative therapy. Go ahead, Richard.
I think you're right. And I think some other adjunctive tools are coming to the market, and I mean the market meaning us, which is, we're always relying on surgical biopsies. Liquid biopsies are evolving. The idea of being able to have point of care circulating tumor free DNA and using that. Like there's a paper being presented at ASCO, which is from MD Anderson. And
Highly suspect already.
I concur. But they did surgical biopsies and compared them to liquid biopsies and were able to initiate treatment 5 days sooner with the liquid biopsies. So I wonder how that evolves, and when we do a sublobar therapy, whether it's surgical or it's an ablation, to understand who's got that viable tumor, if those liquid biopsies are going to serve as our marker for viability, and do we need to do something more? So
Yeah, I'd have to see that paper because we've been working in that area in our own lab, and I got to say that I think this sensitivity, specificity, accuracy, I don't think we're there yet. But hey, there's new data coming out every day, so I don't know about that study yet, but we'll have to pull that
I
out.
think what we may see if we did have an effective way of doing liquid biopsies, and this comes up all the time in the radiation oncology clinic, the patient will say, look, give me the stereotactic radiation. If it doesn't work, then I'll have the lobectomy. And I tell the patients, I said, the imaging, we can't really tell what's going on, and that's why I have an interest in the biopsies as well. But I think that if we had a technique where we could very reliably determine either persistence of viable cancer or early recurrence, a lot of the patients may opt for an ablative therapy and save surgery as a salvage.
Although I do think when surgeons are put in charge of the CT-guided needle biopsies, I think the yield goes way up. I mean, we have our own CAT scan, as you know, Neil, and we do our biopsies ourselves in our room as following in the footsteps of our vascular colleagues. We don't let the lack of a CT scan be a barrier to us. We just lobbied for it and got it put in. Now we partnered with neurosurgery again, but I think when we're doing our own needle biopsies, we're able to be pretty aggressive in getting, we certainly like it to be PET directed when possible and give us, a target. But I can tell you, we're getting pretty good at being able to find focal areas of viability. But we'll see.
I think it's going to be more of an issue if we're treating operative patients. Right now, the majority are non-operative. If they have a local recurrence, our options are somewhat limited. But if someone that's an operative candidate, then we really want to know if they've got a local recurrence.
Okay, well, I guess we should move on to the next talk. Great.
Appreciate it. Thanks.